this lecture, we will cover the innate immune response that our immune system can launch. When our bodies encounter a specific pathogen, we need our system to launch a quick response before the invasion spreads, causing more damage in the system. Innate immunity requires the participation of different cells, including macrophages, monocytes, NK cells, and certain leukocytes. This type of immunity reacts immediately with any antigen, and because it reacts with any antigen, it is nonspecific. And the response does not change with repeat exposure, which means the first time our system encounters one type of pathogen, the response is launched. The next time our system encounters the same pathogen, the same type of response will be launched. This is not adaptive. The response does not change. This is the primary or first response, but it is not specific. It is not adaptive. The good thing, though, is that this reaction is quick, so we can have an immediate response, which is essential. Part of the initial nonspecific response is to create a process called inflammation, and this is very important in defending our system and starting the healing process. So let's look at one example of the steps required to produce inflammation by the immune system. We previously mentioned that intact skin serves as a barrier for foreign invaders. This is a nonspecific physical barrier and part of our natural resistance. Let's say that something happens and the skin is no longer intact. Like here, where we have the puncture wound and there's an opening allowing the bacteria to come in. So now there is an invasion into our system beneath the skin, and there will be an innate immune response. So step one, once the bacteria are present in our system, it will activate the resident macrophages, meaning the macrophages that are already in that area. They are on patrol doing surveillance, and now they can see the foreign bacteria, and these macrophages will react. So we can see here, they will engulf the bacteria. And once it's engulfed, the macrophages will process the bacteria and the molecules it carries, and they are able to warn other cells in the immune system. This results in the activation of certain cells by the message sent from the macrophages. So here they are sending out responses. Bacteria in the system can also activate the mast cells. We already know that mast cells are responsible for allergic reactions. Once the mast cells are stimulated, they will release a molecule called histamine, which mediates the response. It is also responsible for the itchy feeling we get when we have a wound, and we just want to scratch it due to the histamine present making it feel itchy. Once the histamine is present in the tissue, it will dilate local blood vessels and widen the capillary pores. And this allows larger cells to travel from the bloodstream into the local affected area. And these are the white blood cells that are going to help us fight the invaders. So up to this point, we saw that there are bad guys in the neighborhood. Some first responders detected them and started doing some work. At the same time, these first responders called for backup. So we called for more responders to come from the highway. If we think of the blood vessel as the highway, the cells can come off the highway and go into the infected area to help contain the situation. Then during this process, a lot of the molecules are released in the area. So you can see here all the dots representing different molecules. They further attract different immune cells, calling for more backup to help in dealing with this situation. One of the backups is called monocytes. And if we remember, monocytes and neutrophils are white blood cells that are in our circulation. Once monocytes are recruited to the local area with the infection, it will undergo changes to become macrophages. Macrophages will engulf the invader, process the signal, and try to recruit more. So the inflammation process begins with all these cells participating and reacting to the various stimuli. Just to point out, we have the resident macrophages, meaning that these macrophages are already in the location when the bacteria arrives. Then we have the macrophages that are derived from the monocytes that come off from the bloodstream and enter the site of infection. I just wanted to point out the difference between the two, although they all eventually become macrophages with the same function. Again, this is how we produce inflammation with different types of immune cells. This is a summary slide of the stages of inflammation that we just discussed in detail. So, bacteria invades and causes the cell damage. Then we have the different cells reacting. Then these molecules, as part of the response, account for the symptoms we experience at this stage. And also, more importantly, it recruits other cells and molecules to launch further responses. For example, we already mentioned that it has a local dilation effect, which allows bigger cells to travel across the barrier from the bloodstream capillary into the site of infection. Then with all of the immune cells, we will have a battle at the site of infection, which will cause us to see these classic symptoms of infection here. So we have the redness, heat, swelling, and pain. Redness and heat from the activation of the immune cells to that area to fight the bacteria. Swelling is from the widening of the capillary gap that allows bigger cells to travel across, also allowing more fluid traveling outside of the capillary as well. And pain, which is the part of the effect of inflammation mediators that cause this. They not only cause our system to fight the invaders, but also make us aware of this through pain. For most people, they will notice the changes of swelling, redness, and the feeling of pain or itchiness, with the skin feeling hotter around that area than the rest of the body. This is not a system fever. This heat is localized to the injured tissue. Please memorize these 4 symptoms because they are the classic symptoms of active inflammation. With all of this going on, we will hopefully be able to contain the initial infection. If over time the bacteria are contained and destroyed, then eventually the symptoms will disappear. However, if things get out of control, then we will go from local symptoms to systemic ones. So we may get a systemic fever. The infection is more severe than it was in the beginning. So when you discussed obesity and type 2 diabetes last semester, these are the non-communicable or non-infectious diseases. Inflammation was mentioned for both of those conditions, so now we can kind of compare them. With the localized inflammation, it can happen really fast. For example, if we get a skin puncture, in a few minutes we could be observing or experiencing, these responses. If we are talking about an acute inflammation response that is going on in the whole system, it could take hours to days to develop. We would see a fever and fatigue, lack of appetite, an increase in white blood cell count, an increase in CRP, which is an inflammation marker, and things like that. This would be the case if there was a severe active infection or maybe in some traumas, for example. Now, when we are talking about obesity or type 2 diabetes, which are chronic conditions, the system reaction may take months or years to develop. So that is why we call these chronic inflammatory responses. In this case, it is also systemic, therefore the patient may not have a specific site in the body where they see or feel these classic symptoms. But if we do blood work, we would see an elevation of a lot of the immune markers, including CRP, TFN alpha, NFB, and certain interleukins, the pro-inflammatory cytokines. This is the difference of inflammation in these different scenarios. No matter what type of inflammation we are talking about, we need mediators. Remember, different components of the immune system need messengers so that they can communicate effectively and coordinate the response. And these mediators are the cytokines and other molecules that can travel. They can be secreted and then be received by different cells in the immune system. We already mentioned CRP, which is a routine inflammation marker in blood work. We also have the prostaglandins, which are mediators of inflammation that also account for the sense of pain in some cases. Then we have histamine, which is responsible for the itchy feeling that are secreted by mast cells and involved in the allergic reaction. There's also nitric oxide, which is kind of like a double-edged sword. It can kill invaders, but it also does damage to normal tissue when it is generated improperly or in excessive amounts. Please pay attention to all of these mediators. They can be easily measured by taking blood samples, and therefore these mediators can also serve as markers for what's going on in the system. For example, take CRP. The elevation of CRP in our blood indicates something is going on. It could either be a chronic systemic inflammation, or it may be a recent infection, or the body may have received some recent injury. So then we would need to further investigate to see exactly what is causing this elevated inflammation response. Now that we mentioned the mediators of inflammation, we will talk about the anti-inflammatory drugs, which in layman's terms may be called painkillers, because remember, one of the symptoms of inflammation is pain, and pain has its own mediators. Therefore, if we can disrupt the communication during the process, the cytokines or other mediators that are secreted to reach a level of pain where we can detect, and if we have medication that can stop this, it could be a painkiller. There is one category of painkillers called non-steroid anti-inflammatory drugs, NSAIDs or NSAIDs. So from the process of tissue injury to where we feel pain is a multi-step process that involves multiple mediators. Different painkillers disrupt different steps along the way. Once the communication is interrupted, what will happen is that although the tissue injury hasn't been repaired, so we still have that, the initial inflammatory response is still going on. The downstream effect of where we do feel the pain does not receive the proper stimuli. Therefore, the injury and inflammatory response are still active, but we are not getting the feeling of pain. So one questions if this would be a good thing or a bad thing to use these painkillers. Well, the answer is both. We know that pain can be debilitating, so we know that if we have to control pain so that the patient can sleep or eat, then we definitely need to do this. However, do note, pain here is a downstream event and is the consequence of the tissue injury. Having the painkiller does not repair the tissue, so this is a temporary fix. We need to do more to address the root cause of the tissue injury. Was it trauma that we can work to repair? Was it a severe infection that we will need to use antibiotics to kill the bacteria? When we have taken care of the root causes of the problem, for instance, if we have repaired the injured tissue, then the system will calm down in terms of the inflammatory response. Therefore, it will generate less inflammation mediators, including those that cause pain. So that is the ultimate way to treat the pain symptoms. Please be clear that there is a difference between antibiotics and anti-inflammatory drugs. The anti-inflammatory drugs do not kill the bacteria. They just deal with the symptoms by disrupting the communication process, whereas the antibiotics kill the germs and they will solve the pain issue on a more upstream level. So here, this table goes over the inflammatory response in terms of the healing process. Please read this table. So it summarizes how our body progresses in terms of having an initial injury, the response, and eventually coming out of it with the healing process. As you read this, you will notice that each stage focuses on what is the priority at that stage. So this is very similar to our daily decision-making processes. So if there is bleeding, we need to do something to stop the bleeding. Then maybe think about getting rid of the scar tissue later on if we can. Or if it's a bone fracture, we will have the bone fused together first, and then the remodeling will take care of the scar tissue later, to a point that if we do an x-ray at some later point in time, we would not be able to tell that the bone had a fracture before. So it focuses on what is the most urgent thing at the moment. Again, please read through this table of the 3 stages carefully. Now, we mentioned that if someone gets an infection, their nutrition status plays a key role in being able to fend it off. Also, in the case of infection or wound healing, nutrition intervention plays an important role in the recovery process. This table on this slide and the next few slides are from the textbook, so we will briefly mention a few key items in wound healing for adult patients. But please read this carefully. You'll find that you'll be able to get a lot of use out of it during your clinical practice. So for wound healing in adults, it could be from trauma or maybe from surgery, or it could be due to a pressure ulcer, which is prevalent in certain populations. All of those have tissue damage, and they're all situations that would require us to support the process of making new tissue so that the wound would heal. To heal any wound, we need to make more molecules, so it is an anabolic process, a synthesis process. Therefore, we have to provide a lot more energy than what we would need if that person was healthy. Depending on the level of injury or the wound, we have different allowances of energy based on kilogram of body weight. So when you're completing your clinical rotation, usually the facility will have in-house standards. For example, pressure ulcer stage 1, they will specify the amount of energy per kilo needed. So please be aware of the facility standards and be sure, of course, to follow them. We also need an additional amount of protein. The RDA for adults is 0.8 grams per kilo, whereas wound healing, in that case, we could even double the amount because we need additional amino acids to build extra protein so that the wound can heal. Then we have some other items. So PUFAs, for example, the omega-6 and omega-3. These are implicated in the inflammation process. And generally speaking, omega-3 fatty acids are anti-inflammatory, whereas omega-6 fatty acids are pro-inflammatory. So it is indicated, although we don't really have clear recommendations as to how much to give for each category. Then for fluid, we do need to have adequate fluid intake because the patient with wound healing will have higher needs or turnover. For example, if the wound is still open, there is the evaporation of water, so the fluid loss will be much more. Also, open wounds leave a site for bacteria or other microorganisms to enter to cause infection. Once the patient develops a fever from this infection, then the fluid needs will increase even higher. Therefore, we really need to provide an adequate amount of fluid depending on the situation. In addition to those macronutrients and energy, we also need to pay attention to some of the micronutrients. For example, vitamin A, C, and zinc. These are called for if we want to promote wound healing for different reasons. To make new protein to heal the wound, we need certain genes to be expressed to make this protein, and vitamin A and zinc are required micronutrients for gene expression. Also, vitamin C is required to make normal collagen protein, which is a very important protein structure in any tissue. Remember that we have 4 different types of collagen proteins. So the presence of vitamin C in the synthesis process allows collagen proteins to be stable. Therefore, these 3 micronutrients are often prescribed for patients who need wound healing. Although keep in mind that vitamin A and zinc should not be used for prolonged periods of time because of the potential to develop toxicity. The in-house guidelines at your facilities for pressure ulcers will also specify how much and for how long the micronutrients can be prescribed to promote wound healing. Studies that indicate for iron that it does not need to be routinely supplemented for wound healing, because these studies indicate that low hemoglobin status does not delay the wound healing process as long as the perfusion is maintained. So that means as long as the blood is flowing to the site of the injured tissue or wound normally, we do not need extra iron to promote the process. Then we also have other micronutrients and other potential supplements we consider. So please read these 2 slides on your own.